Yeah, thank you for inviting me back. It's really my pleasure to be here. My son Andrew also sent his greeting from University of Southern California. He's getting his degrees in a doctorate in pharmacy and also master's in regulatory science. Unfortunately, he's still attending classes, so he can't come, but his heart is here. Okay, I was asked to give a clinical talk on this illness. This is what happened in 1998. A year after my son became ill, and I finally, as a dad, realized my son was sick. So I read a whole bunch of medical papers, and this was the confusing picture I saw. There's many symptoms the patient report, and we often thought they were crazy, as you can see. And there's many potential etiologies, and on one side of the argument was that this is all psychological, and the other side that maybe this was an infection. Certainly, I did not put a whole lot of stress on my son because he was a good kid. He was a good student. He was an athlete. But he became ill after respiratory illnesses. So when I look at the center of this picture, which is on the verticals, you can see the myalgic encephalomyelitis in a very interesting font, and enterovirus across horizontally. I look at the papers done by the British investigators. I found these to be really interesting. I said, unless they blatantly lied about their findings, I can't believe why these were denied in the first place. So we decided to work in this field. But as a clinician, I used to work in HIV in the laboratory, and I did have some training in virology, but at that time, I didn't really have a laboratory approach to this. I said, how do I approach it as a clinician? Well, one of the problems we see in infectious diseases is what we call fevers of unknown origin. And people have fevers, just like people have fatigue. Well, you don't know what is caused by. And the best thing to do with those patients is get a detailed history. So the history is really the most important. Why history? Well, our professors have told us many times, unlike the young physicians may be coming out, the patients are very intelligent human beings. They usually tell you what the answer is, or at least give you the right approach, head you to the right direction. We don't listen to them. We don't want to spend the time with all the things they want to tell us. We'll pretty much miss the diagnosis, right? So this is how I approached it in the beginning. So let's say if enterovirus is correct, there's something about the patient history that would actually fit this. So I took a detailed history of the initial events that led to the symptoms of ME/CFS. And it's interesting, I noticed a few things that has come back again and again in patients' history. Traveling history. Overseas traveling or traveling to, like I'm from Los Angeles, people gone to Mexico, Las Vegas, and sometimes to Southeast Asia, water exposure to lakes, to rivers. Since Los Angeles is fairly hot, whenever there's a time on vacations, the patient often go to a lake for water sports, and they often become ill after they come back. The patients who go surfing in the brackish water in our LA, Los Angeles beach. The beach looks beautiful. The water is pitiful. And the sewage line is right next to it. Any respiratory and gastrointestinal symptoms, causing, infections, flu-like illnesses, the use of steroids, not anabolic steroids for physical training, but when patients were ill, the patients were given glucocorticoids like steroids, prednisone, etc. This was something that kept coming back. Yesterday I was talking to someone, and this history came out again. Surgeries, right lower quadrant pain, appendicitis or suspected appendicitis, that tells us there was something going on in the terminal ileum. Vaccinations, which is a very strong risk factor in some of the patients. Mold exposures, ill contact with someone who's been sick, especially young children. But young children could have some viral illnesses, but when the adults get it, it's totally different. They actually get the organ damage rather than having a simple cold. Tick bites to look for certain unusual diseases, as Lyme disease or borreliosis. Part infections in childhood are quite important. Recurrent sore throats. Patients do not really have documented strep throats, streptococcus infection, but have these recurrent sore throats. If that were a virus, it's very clear the virus was not cleared the first time. That's the clinical way of looking at it. Ear infections, colds, tonsillectomies. Why do people get tonsillectomies? Because they have recurrent sore throats. Asthma, that is like the wrong immune response toward an allergen or infectious agent. Neonatal fevers in the first month or so, are highly suggestive of enterovirus infection, and they have a difficulty clearing that. Detailed review of the medical records, special laboratory tests, which has been done, will be very helpful at this point. Just a quick review of the symptoms of acute enterovirus infection. This is kind of important, so you kind of recognize what acute enterovirus infections are like. Well, in the United States, it's estimated more than 50 million people get sick every year. Many patients could be asymptomatic. That means they have very little symptoms, or there are not even symptoms at all, no symptoms at all, as in poliovirus infection. But a large number of people do come down with respiratory or gastrointestinal infections. The respiratory tree, the virus enters, could include the nose, the sinus, the throat, the larynx, the airways, the lungs, causing a variety of these medical terms. And gastrointestinal infections usually start with nausea, vomiting, abdominal pain, either upper or lower, and diarrhea, which are common. But the viruses can also enter the organs and causing liver infections, pancreatitis, Dr. Chapman alluded to, colitis, etc. Some patients don't have all these obvious symptoms, but if you ask enough questions, yeah, they had a little runny nose, little sore throat, little diarrhea. But the predominant symptom is the fevers. 102, 104 fevers to last as long as 3 weeks. Sometimes it's associated with very low white blood count. In my experience, enteroviruses is the most common cause of leukopenia, along with flu-like symptoms. H1N1 can do the same thing, but it's much less common. It can cause bone marrow failure, which has been well reported in immunocompromised patients or neonates. Then these viruses grows in the respiratory tract or the gastrointestinal tract, then they will disseminate into the brain, the meninges, the spinal cord, or the hearts, the various layers of the heart, then we call them different names, and the symptoms are different. Or to the muscles. Some patients will develop severe muscle weakness with little pain, that's myositis, or severe pain over the chest, that's what we call pleurogenia, or Bornholm's disease. So these viruses are capable of involving many, many different areas of the body. Skin rashes are quite common. And just yesterday alone, I heard 2 people talk about chickenpox-like rash in patients who develop a flu-like illness. The enteroviruses is the greatest mimicker of chickenpox. If the patient already had chickenpox before, then later on developed a flu-like illness with chickenpox-like rashes, that's enterovirus until proven otherwise. But the rash could look like measles, German measles, it could look like hives. So very often people travel, ate some shellfish, and developed these hives all over. Went to the emergency room doctor would say, oh, well, you ate lobster, you must be allergic to shellfish. So what's the next thing they got? They got prednisone, steroids. And that disease never ended. They developed chronic fatigue syndrome after that. We hear this hundreds of times. These viruses can cause rashes in the mouth, which are very characteristic. I'll show you that in a second. But one thing we did notice as we keep chasing this virus is that how does virus do such a good job, and how can they actually eventually become chronic in a patient? So we actually look at some, because we have seen clusters of shingles occurring. Over the years, I've probably seen at least 100, 200 cases of shingles, and one of the dermatologists told me in 2-day period, he saw 22 cases of shingles. Shingles is reactivation of chickenpox virus. Epstein-Barr virus or herpes 6 virus, when it's reactivated, is hard to see. You really have to think about it. You have to do tests to confirm it. But chickenpox showing up as shingles, you know the virus reactivated. So I thought this may be a good area to look at it because I knew a number of these patients had a prior respiratory or gastrointestinal infection. So what we found when we investigated 5 cases is that there's the T8 or the CD8 positive lymphocyte counts dropped dramatically. So did the CD4 count, but much less so. This is totally reverse of HIV. And this is totally different from Epstein-Barr virus. You can actually tell by looking at this. So it was very interesting that the TA cells dropped profoundly, but in 2 months or so, when we repeated it, it came back to normal. This is comparing with my chronic, the CD8 cells of my chronic fatigue patient. You can see there's a big difference here. Recurrent shingles in most of the patients are independent of subsequent CD8 count, but a couple of patients that have very low CD count, CD8 positive T lymphocyte cells, they have recurrent shingles. We have to keep them on acyclovir. We couldn't even stop it. Whenever we stop, the shingle will come back. How do we diagnose a chronic enterovirus infection? Well, the most important thing to me as a clinician is to recognize or listen to the patient to recognize what that acute infection is. Yes, flu-like symptoms are very similar, but influenza rarely lasts more than a week. Colds don't last more than a few days. Gastrointestinal infections, like say norovirus, can be very, very severe, but never last more than 2 days. So something that lasts more than a week or 2 or even 4 weeks, you know there's something else. But very, very few viruses can cause prolonged infections like that. So a high index of suspicion is important. Details of the initial flu-like illness, even a little runny nose, sore throat, diarrhea is very helpful. There are actually very few physical signs, but I'll show you these pictures. Tongue ulcers and abdominal and muscle tenderness are helpful. Then the testing for enteroviruses is still quite limited. Largely, I still do the antibody test. This is available in the United States through ARUP laboratory for only 11 out of now over 100 enteroviruses. So our ability to diagnose these viruses are relatively low, but we can at least give us some idea if we can detect these viruses. We can do a quantitative RT-PCR to look for the gene of the virus in the whole blood of patients with ME/CFS, but this has a very low sensitivity because the viral load is very low. We'll tell you about the immunoperoxidase of tissues. We can find it in the stomach and many other relevant tissues where patients are reporting symptoms. But the most important thing is remember that you have to correlate the symptoms and the test results. If the test is positive, the patient has no symptoms, what does it really mean? Okay, here are some of the examples of tongue ulcers. You can see on the edge of the tongue, you get 2 ulcers here and here. It could be in the center, it could be in the back toward the tonsils area, and it could be somewhere else. But these are very helpful. These are patients with positive RNA in the blood, so we knew these are related. This is a gay male who actually developed chronic fatigue syndrome before he developed HIV. And this was the very first thing he remembered. For 25 years, whenever he had a major flares, these will show up. There's only one type of virus that can produce these type of lesions. These are called herpangina. It's interesting that this patient with HIV actually has been on numerous regimens of anti-HIV medications. His chronic fatigue syndrome has not improved. But quickly review some of the literature the British investigators generated. This slide is important because there was a 130-year-old female that developed ME/CFS for about 5 years and committed suicide. Before she died and was extubated, the family gave doctors the chance to find the virus in her tissues. So they were able to find enterovirus RNA in the muscles, heart, hypothalamus, and brainstem. And the RNA sequence shows about 83% homology to what we call Coxsackie B3. There's only one patient, published in 1994. That has not been done again, but you don't get the chance like this very often. But this clearly shows the virus can go through the various areas where the patients are complaining of the symptoms. The other study that needs to be quoted is this blinded control study done by Clemens et al. And they were able to find enterovirus RNA in the CF patient's serum, about 41%, and the control serum was only 2%. Unfortunately, our American investigators could not reproduce this finding. So basically, this was left in 1995 as probably a disease of the mind. And because of some of the special comments made, but I'm not going to go over that issue right now. So when my son got sick in 1998, eventually we found a technique that we can actually use to look for enterovirus. So from that point on, we actually did initially a blinded studies, and we found that 38% out of 131 patients with CFS tested positive for enterovirus, and only 4% of 52 controls, these are spouses or relatives of these patients, that actually were positive. So this was highly statistically significant. This actually reproduced the results of the British investigators. For the next 5 years, basically we tried to figure out why sometimes we see it, sometimes we don't. So we painstakingly taken actually more than 3,000 blood samples from more than 500 patients. And we found out about 35% of the patients had the viral RNA in the blood, in the white blood cells, at least once, at least twice, actually. But if you look at it, when we took the blood samples every 3 months or so, some are positive, A lot of them are negative, sometimes they're positive again. We couldn't really understand this, and this really frustrated us and said, why are we doing this wrong? And even after optimizing the technique. Well, eventually, when we had better tubes to preserve the RNA, the gene of the virus, now everybody uses this. It's very, it's kind of foolish to talk about this, but in the old days, actually, this was not available. So when we use the PAX gene tubes, just in one draw, we can see the positive test in 29% of the patients. Okay, and many of these samples were confirmed by sequencing. Then when we did the quantitation, but then we figured out, we said, maybe there's very low amounts in the blood. What we actually figured out was the median value of the copies was 53 copies per milliliter of blood, and the mean was 200 copies. You can see here, most of these are very low levels. This probably explained the discrepancy from the various laboratories. It's not there. It's just it's very low. So this is not really the best way to find it. So after spending 6 years knocking our head against the wall, we said we must try something else now. Maybe we can find this a little bit easier. And so a lot of patients had gastrointestinal symptoms, and we luckily found enterovirus RNA in the terminal ileum, the distal part of the small bowel, in one patient. Then subsequently, we started working and actually thinking practically, how can you find this virus elsewhere? Well, the virus has to be swallowed. Either if you had a respiratory infection, you swallow the respiratory secretions, or you eat or drink water, okay? The virus will hit the stomach first. Here is a picture of the endoscopy, and you can see some red areas. This pink area is normal, so you can see a little bit subtle changes here. When someone that has much more severe inflammation, you can see all this red area. But interesting enough, someone had this much red area may not have symptoms. So it doesn't always correlate. It doesn't have symptoms in the stomach. So we did the viral staining. All the brown spots on the background of blue, the brown spots are the viral protein. So on the first top two panels, you can see there's a fairly extensive staining. That's what we call 2+. Here you can see much less staining. It's called 1+. On the right lower side here, there's really no staining. That's negative. We were able to correlate that the patients who are severely ill have much more likely to have more protein staining, viral protein, than the people who are less ill. When we published this data in the Journal of Clinical Pathology, initially we had 165 patients. 82% of them stained positive for enterovirus protein, and 20%, or 11 out of 56 of the controls, and 32 of these were blinded samples from a gentleman in Texas. So these patients tested positive. The difference was obviously statistically significant. Well, to date, I'll just move quickly since I do have a lot of slides to talk about. And we have done 450 slides now, and there are 82% positive samples. If we use 2+ staining as the positive test, so if more extensive protein is more predictive of an infection, then 54% of the patient had 2+ staining, and the specificity is about 95%. Then, in addition to this type of work, we did find the gene of the virus, RNA, in the biopsies. This was difficult to do. Then this was even worse. So we're trying to find the virus after we actually talked to Nora a number of times. And initially, when we used this type of cell line, and then we found the initial experiment, we had 7 out of 13 were positive. That's called the beginner's luck. It never reproduced since then. So out of 75 samples, only 9% were positive. That was the original 7. But these were real, since we were able to pass it from the first culture into another second culture, and the virus grew again. Then we also tried the Vero 76 cells, and 3 out of 22 were positive. And this WI38 you saw in Nora Chapman's slides, 9 out of 35 were positive. So altogether, about 19 out of 130 samples were positive. But the interesting thing is that we couldn't keep these viruses alive in the test tube. Now we're actually able to make some clinical pathological correlation. This is important because if a patient has a symptom, you have to be able to demonstrate what the virus is. Here is a young lady's abdomen. You can notice that there's some mild distension. The patient consistently complained of epigastric pain, nausea, right lower quadrant pain, and left lower quadrant pain. And when I pushed on it, this axis can definitely tell me the tenderness. This is actually a fairly reliable sign to detect enterovirus infection of the abdomen. So in the stomach, we can demonstrate all this viral protein in the stomach biopsy. In the terminal ileum, we can see the swelling of what we call the Peyer's patches. These are like lymphoid tissues in the terminal ileum. Just in a very small area of biopsy, we actually found 100,000 viruses, actually on an 80-micron cut. So just in this area alone, there's probably 50 million viruses. These left lower quadrant is more suggestive of the colon, and in the colon biopsies, we can see extensive viral staining of the colon, even down to what we call the crypt. And then one of the patients actually lost her colon, which I'll show you later. You can see the viral staining of the muscles and maybe a little bit of the nerve cells. Here's the patient with a chronic sore throat. Finally, she was sick and tired of this complaint. She said, I want my throat biopsied. So out of 5 biopsies, this one's negative. This one, you can see the virus-infected macrophages in the posterior lingual tonsil. 5 years later, the patient developed thyroid cancer, but she already had a baseline of Hashimoto thyroiditis, which I'm sure most people know about this, the association of this with chronic fatigue syndrome. We're able to see enterovirus protein in the follicles, follicular cells of the thyroid in the background of inflammation, which is Hashimoto thyroiditis. Patients often have chronic sinus complaints if they started with a respiratory infection. So if this is a virus infection, we should be able to show this in the sinus tissues, and that's what we show here. This is actually the same slide stain with CMV antibodies. You don't see any brown spots. Here you see it. We see this about 50% of the time. It's less sensitive compared to the stomach biopsy. Here's the patient, went to Costa Rica, got sick with a violent GI infection, was hospitalized 3 different times in the hospital. We were actually able to find the viral protein and RNA in the initial biopsy on the first hospitalization. And then over the next year, she had chronic abdominal pain, and she couldn't even have a bowel movement in 2 weeks, despite of whatever she tried. So she had manometry studies that showed that the colon did not move. So her entire colon was removed. She actually felt a little better afterwards, but she's still very fatigued and all this. But if you look at here, you can see the muscles are infected with the proteins are positive. Here's the circular fibers, these are longitudinal fibers, and here's the nerve cell. This is called the myenteric plexus. This is the telephone poles in the colon, and the wires are connected here. This is one of the nerve cells is infected. Here's a patient with chronic fatigue syndrome and pelvic pain. The pelvic pain syndrome obviously is one of the symptoms, one of the problems the patient have. And actually, because the left lower quadrant pain was so bad, she actually underwent a removal of her ovary and the tube. Here is the fimbria of the ovary. You can see the extensive viral staining here, and with a CMV stain, you don't see it. It's interesting that this actually correlated with improvement of symptoms after the removal of the tube and the ovary. So this probably does correlate to some extent. So after all that, a quick review, what do we do about all this? Well, currently there's no, in America, called FDA-approved drugs. So largely we treat this based on, number one, symptoms. I think that's important. Dr. Cheney, I'm sure, is going to talk about some of this. There are specific antivirals we have tried. Pleconazole we obtained on the compassionate use for enterovirus. It didn't work very well. Well, there are future antiviral drugs, but none of them are geared toward enteroviruses, but they're used for other viruses, which eventually we'll have to borrow from and see if they will work for our viruses. There are other antivirals people have tried, acyclovir, ganciclovir, or Valcite, and cidofovir. We certainly have tried a number of those. If enterovirus is what we're treating, then these drugs don't work very well. If the patient has a dominant player like Epstein-Barr virus or CMV-HHV6, which is a very minority, a small minority of the patients, these drugs actually do help to get into a better state or actually into remission. So immune modulators, Ampligen, you'll see in your handout, there's some data there. I have very little experience with this. I do know some physicians here have had fairly good experience with a few patients, but unfortunately the FDA doesn't look like it's going to approve this drug. IVIG, we're not going to talk about very much, but in my experience, 1 out of 3 people do respond to this, especially the patients with a lot of pains, a lot of muscle pains, fibromyalgia patients. Interferon I rarely use now because of the expense and also the toxicity, but almost 48% of the patients respond. Patients who have had severe pain for over 25 years, the pain will go away in 2 weeks with treatment. It's pretty dramatic. We usually give it to them for three months. That will cost $15,000 in the United States. And the pain will go away completely. for 2-3 years, then you will relapse. And thus, we have plenty of those patients. The next thing is what I've been using. It's called Herbal immune boosters. I just want to give you 2 brief examples how the immune system works. On the right-hand side, this is case 1. A 40-year-old male cardiologist developed an upper respiratory infection after ill contact with his son. 48 hours later, he had thigh and leg soreness and weakness, and mild fatigue, able to work. His muscle enzyme was 26,000. Normal is up to 250. Then about 48 hours, it dropped down to 2,000. Then another 48 hours, it was completely normal. Then he had no further symptoms after the first week. His troponin was negative, so he didn't have any heart involvement, okay? So this patient cleared the virus, even though the virus reached the muscles. The body eradicated it, and he had nothing more to deal with. This unfortunate gentleman was 15-year-old, and he had a flu-like illness during the basketball season. He was a freshman playing in the varsity. He was a very good player. And he kept playing while he had the flu. Then eventually, he got so bad, he was bedridden and homeschooled for the next 4 years. Which athlete want to stay home for 4 years? Nobody, right? He eventually improved and went to college. Then he saw people playing basketball. He said, I better play basketball. He played 3 days in a row. Then he developed a severe diffuse muscle pain. The next day, the mother brought him in to see me as an emergency. CPK, the muscle enzyme, was 30,000. Again, 250 is the upper limit of normal. And in 1 week was still 10,000. Then normal in another week. So let's take a vote. What happened to this young guy? Do you think he relapsed? Raise your hand. Okay. How many think he recovered? Nobody. Well, the answer is there's no right and wrong answer. The answer is that he eradicated this and never been sick again. Okay. This is how I look at this immune system. Dr. Nancy Kleinman's Paul Cheney even talked about this years before I even started looking at this issue. But the way I understand it, I show this the last 2 years. In case 1, which was on the right, when a virus enters, had a limited dissemination into the muscles, the immune system mounted a Th1 response. Then basically the immune system did the right thing, pour out the good cytokines, formed a nice orchestrated immune response. You got rid of the infection. So in a week time, you got nothing to deal with, basically, nothing more. And that's usually what happens in most cases of enteroviruses, including polioviruses. But if patients have certain type of circumstances, such as if the patient had a long history of allergies, asthma, allergic rhinitis, they tend to shift into the Th2 direction. Glucocorticoids, if patient develop a viral infection and with symptoms suggestive of asthma, they're often given steroids because it's the mainstay of therapy. That can shift the immune response to Th2, not to mention you will drop the T lymphocytes down to practically 0. The second half of the menstrual period, so 2 weeks before period, the immune system shift to Th2. Maybe this is why we tend to see this illness starting in puberty, and maybe this is why we see it more in females. But pregnancy certainly is a Th2 dominant system. In pregnancy, we know the pregnant women have a difficult time with viruses, especially you heard about H1N1. But not just that, chickenpox, enterovirus, etc. Vigorous exercise, marathon runners actually tend to shift into this direction. So if they had a cold, it would take longer to get rid of it than a normal person. Vaccinations often will shift into this direction. And prior infection, fairly close space or separate infection, will shift into Th2. Well, that's what happened to this young man on the left side, okay? He went to Th2, and then he could not eradicate this infection. He basically lived with ME/CFS for 4 years. But in 4 years, he basically didn't do anything, okay? Let's say the virus controls this immune shift, which I think is what happens. It's not destructive, but controls it. Shift it into the wrong direction so the immune system cannot kill the virus. But over the period of time of 4 years, the virus load gradually dropped. The immune system started shifting. The red started shifting toward a horizontal line. And then when he played basketball, I think he basically shifted into the Th1 direction. He actually lysed or killed the infected muscle cells. That's why those muscle enzymes get released, very similar to the first patient, okay? Then his infection is eradicated. That's the good news. So there is an immunologic approach which many people have used before I even tried. When we started doing cytokine gene expressions after other people have done such good work, which is why don't we try it? This is also called beginner's luck, because the first day 4 patients came in, you can see this one that kind of stuck out like a sore thumb. The other one are kind of about the same. There's 3 other patients. This one patient is a 38-year-old psychiatrist, can work 8 to 10 hours a day dealing with doing addiction medicine, but she had to drink 8 cups of Starbucks a day, okay? But she can stay up. The other patients can drink 8 cups of Starbucks a day. They still a lot bedridden. You can see the difference. This really stuck out like a sore thumb. This actually is interleukin 12, P40. So we said, well, and you won't be able to see this, but interleukin 10 for her was much lower than the other people. So what we thought to ourselves, why don't we just look at all these cytokines, which there are 12 of them, and compare to the CFS patients and the patients who could work. They were having much more severe symptoms of CFS. Now they have improved to a certain extent that they can work part-time or full-time. For most of the cytokines, there's really no difference. Here is actually a ratio of the IL-12, P35 plus P40 over IL-10 compared to, say, the people. This is the one that can work. This one cannot work. You can see there's a big difference here. So we'll come to this in a second. So at about this time, we also started using the Chinese syrup. We had the patient import a preparation from China or Hong Kong. And the way we did it, because we didn't really have any funding, so I said, well, we got to do a quasi-study. So the first 100 patients we gave to, okay, about 52% of these patients responded. The next 114 patients I did not treat. So I waited 3 to 6 months. And then only 7 out of the 114 improved on their own without treatment. So these are consecutive patients. We did not exclude anyone. Anybody who dropped out after taking 1 pill is considered a failure. Okay, so it's intense treat analysis. The difference was statistically significant. Let's go down to here. Then initially, we're just treating these patients about 3 months or so. Then we learned very quickly. After they stopped, the patient relapsed very quickly. Okay, so they were better, but then they got worse afterwards. Most of the patients went back on it, improved. Now we have given this to 366 patients, and it's still about 52%. And these patients responded to oxymetrin. And also, I forgot to mention this. So out of the 114 patients on this control group, 104 patients we gave the same oxymetrin. We came up with about 52%. These are examples of how these patients responded. So you get an idea of what happened. Some patients did not respond at all. As you know, 50% of the patients did not respond. Some had mild responses, and these are the dramatic examples. So one guy is 59 years old. He had 2 back-to-back infections, respiratory and gastrointestinal infection, and then developed severe CFS. He was bedridden for 18 months, couldn't work at all. He had epigastric and right lower quadrant tenderness. His enterovirus serologies were negative, but we found the viral protein in the stomach biopsy, actually quite a bit of it. So he took oxymetrin for 2.5 months, and nothing happened. Then all of a sudden, he started having fevers for 4 to 5 days. This gentleman could not do anything except taking his son to school in the car. The rest of the time, he's housebound. He couldn't do anything, okay? So he had no exposure to any sick people. His wife and children were not sick. So he had fevers for 4 or 5 days, and his body aches were a little better. It meant he had some mental clarity. Then the next 10 days, he took this Chinese syrup, no more fevers. In the next 2 months, he went back to work full-time, and it's been 3 years in remission. It's interesting that when I saw him, every time I see him, he still has a little bit of this right lower quadrant tenderness, suggesting that there might be something still there, but his immune response is much better in guarding it. The second patient is a 25-year-old female with ME/CFS for 5 years. Energy levels about 3 to 4 out of a 10, diffuse myalgia, cognitive function, et cetera, et cetera. The Kawasaki B4 antibody was greater than 1 to 640 repeatedly. So because she had a lot of pain, which I think is inflammatory response, these patients don't tolerate high doses very well. So I said, why don't you just take 1 tablet a day and see what happens? I expect you to have some increase in symptoms in the beginning. Well, she did have that for about a week. Then gradually over the next 10 days, the body ache disappeared completely. The next week, she went out jogging 3 times a week. It's pretty amazing. So she felt pretty normal in 2 months, and she said, well, I feel normal, why don't we just stop it? Okay, she stopped. 2 months later, all the symptoms came back. It's very hard to get rid of these guys, okay? That's one thing that I always know in this type of illness is relapses. This is no different from hepatitis B or HIV. If you treat the patient with good drugs, antiviral drugs, you stop too soon, or in HIV case, you can't really stop. The virus will come right back. This is an interesting patient that actually had a very nice response. She was a marathon runner before, became ill with a respiratory gastrointestinal infection, flu-like symptoms, while training for the race. So she didn't make it through the race. She almost died, she said. But she was bedridden for the next 2 years after the race, able to set up, do business on the phone or the computer for 1 or 2 hours. She's basically housebound, couldn't do anything else. She took the Chinese syrup 3 times a day, had an initial increase in headache, body aches, gastrointestinal symptoms for 2 weeks. They felt pretty normal by 3 months. She sat there and she said, I feel normal, okay? And I was dumb enough to say, well, why don't we just stop and see what happens? So within 36 hours, she had a marked increase of all the pre-existing symptoms. It was even worse before she took the herb. And it's interesting now, before she was taking 6 a day, she couldn't even tolerate a half a tablet now. The pain would get so much worse, okay? 6 weeks later, she said, I have to get back to that state. This has not happened to me for 2 years, okay? I want to try something. So I put her on a half dose of interferon, this is called Pegasus, every week. Then in about 2 days, I told her to go back on the Chinese syrup. In the next 3 weeks, she actually worked up to 6 per day. By the end of the 3 weeks, the body ache went away completely. She was on the combination for 6 months, then we're on the Chinese syrup for another 18 months. So total treatment was about 27 months. She's been off for more than 8 months. She only has mild symptoms, 1 day out of a month. It's exactly the same symptoms she had before. This is always before her periods, okay? It's telling you this isn't gone yet, but it's much better control. So when we did the cytokine gene studies, this is IL-12, P35 plus P40 using the relative ratio of the gene expression over IL-10. All the top 7 patients responded by shift into the Th1 direction, okay? Had a 2-fold increase. My son, I think, is the second one or the third one. All the 10 non-responders did not change at all. So there is some indication that there is some cytokine gene changes. The side effects are basically increase in all the pre-existing symptoms. If you have to go through a fight, instead of using ineffective weapons, you're shifting the immune response toward the more effective immune response, then you have to fight another battle. So a number of the patients will have increased body aches, headaches, abdominal pain, nausea, diarrhea, fatigue, whatever they already had before. Some patients with interstitial cystitis, the bladder symptoms can get a little worse, dizziness, insomnia. A couple of patients complained of weight gain. They feel more hungry taking the herb. 1 or 2 patients had increase in swelling, but they already had before. Joint pains. 1 patient out of 500 actually developed rheumatoid arthritis while taking the immune booster. She has a very strong family history of rheumatoid arthritis, was having severe joint pain even before the herbal treatment, and now she's on treatment for rheumatoid arthritis. She's doing fine. 2 patients had transient increase in blood pressure, rashes, dry eyes, mouth, and it's interesting that we had 2 patients that took this for about 2 months and just continued to have headaches and no improvement. So instead of tapering off the Chinese herb, they abruptly stopped it. In the next 24 hours, the patient had a huge herpes outbreak. Herpes 1 in one, herpes 2 in another one, which they have not had for a long time. So maybe the mechanism of action is correct. Maybe we're trying to shift the immune response over, but it's almost just like spring-loaded. And when you stop abruptly, it will go back down, and maybe even worse. This is a product that my son and I actually formulated, because to get this oxymetrin from Hong Kong, it was a little bit tedious. So we formulated it, had one of the American companies make it. This was done under the good manufacturer practice. So we used this in over 134 patients, and it had about a 56% response rate. But maybe I'm a little bit better in picking the patients. The patients who have severe pains, I usually don't start them on this. People are just fatigued. This is not a bad thing to try. 88% of 51 patients actually switch from oxymetrin to equilibrium and have continued improvement. Other patients may have some minor issues, so they rather take the regular Chinese herb. This is better tolerated. Part of it may be because we started the dose much slower. And typically, we start with 1 tablet a day for a week to 2 weeks, and then gradually increase to 4 to 6 per day. My son and I basically took 6 a day to start with, and the increase of pre-existing symptoms is still quite common. This is an interesting patient. This is the second out of 500 patients who took the Chinese syrup. This one was on equilibrium. This is a 13-year-old child, actually has ME, CFS, and pronounced gastrointestinal symptoms. By the time he saw me, he is already on nutrition by vein because he lost 30 pounds, he couldn't eat. And his stomach biopsy was markedly positive for enterovirus. His antibody tests actually were negative. So when I look at his T cells, the CD, the T3, T4, T8, they're all below normal. So when the patient took the equilibrium, about 2 months, the number all went up. Interesting enough, another 2 weeks later, he actually was hospitalized because he had fevers for 4 days, just like the one I showed you before. And they thought he actually had a line infection, for giving the intravenous nutrition. Actually, there was absolutely no evidence for line infection. So I repeated his T cell count as he was hospitalized. You can see the T3 went out even more. This is when he had fevers. And actually, the CD8 increased out of proportion to CD4. Actually, almost met here. And then 2 weeks later, we measured again, kind of dropped down to about the 2-month mark. He's feeling much better. We don't know what his outcome is because it's still early. This only happened about 6-7 weeks ago. We have some evidence, about 5-6 patients now. We've done stomach biopsies before the treatment and also during treatment or after treatment. So this is one good example of a patient who could not work, actually has a lot of stomach complaints. So we did a biopsy right before the treatment. She has 2 pieces of stomach biopsy look like this. You can see all these brown spots. It's just loaded with virus. This is 100x magnification, 400x magnification. One piece has some brown spots. This piece is negative. After treatment, 2 pieces look like this. This is the 100x magnification. This is the 400. You compare this one and this one. It's 9 days. There's a marked reduction of the viral protein. And the 2 pieces were negative. Excuse me. The reason we do 4 pieces of biopsies is that there's sampling error. So if you just take one, you're going to miss it. So 4 pieces is probably the best thing to do. The next thing that we're thinking about is that obviously this Chinese herb does help patients, but we need something better. Just like Nora talked about in the heart infections, we believe that there is this double-stranded RNA in the cells. And these double-stranded RNA can open up into the positive and the minus strand, and these can multiply using a viral enzyme to make more of themselves. Part of it is being degraded. It's like a race. This is keep making it, our body keep destroying it. But unfortunately, in chronic diseases, they're always winning, aren't they? Right? Because once they die, there shouldn't be any more chronic diseases. So, but enough of these will recombine into this double strand. These are almost like what we call the seeds of weeds. Okay? It's kind of hard to kill them. But there's mechanisms we can actually attack. For instance, the enzymes that multiply the genes. Some of the viral gene is made into viral protein, which you can show by the immunoproxy test. Some defective viruses does come out, like Dr. Chapman discussed, and we also found in the stomach. But all this process going on inside the cell does elicit an immune response. But the immune response, one of which is the neutralizing antibodies, which we can measure in the blood. This is a paradox I finally figured out, because I said, why is there a persistent virus infection when there's so much neutralizing antibody in the blood? The antibody should neutralize any viruses, right? Well, not when they're in the cell, inside the cell. If they're hiding inside the cells, we can't touch it. So, but the viral protein being produced is triggering all this neutralizing antibody, which allow us to diagnose this disease by looking at these antibody levels. Some of this can trigger interferons. Interferons can turn on this system just as Ampligen can turn on. And this will try to degrade this, but eventually the patient with ME/CFS is still losing until we can effectively interrupt these mechanisms. That will come. This is a treatable, and in my humble opinion, it's a curable disease. So I'd like to acknowledge the people, especially Nora Chapman and Steve Tracy's work. I mean, you have certainly illuminated this field for me. To this day, I'm still, I'm like a sponge sucking in that knowledge, okay? There's still too much to read. I still have to figure out what all those slides mean. And my wife, Lucilla, for being with us. for being with me and my son in this endeavor, Mr. John Chia for his generous financial support, and all the patients who's been with us and participated in the study. Thank you.